if there is no more questions, I would like to invite our second speaker, Professor Marek Swoboda. Professor Swoboda is General Director of Masaryk Memorial Cancer Institute in the Czech National Cancer Center, and is also a member of our accreditation committee and represents Central European countries in Mission Cancer boards. And Professor Swoboda will tell us about the policy, advocacy, and healthcare reform and roadmap to reducing cancer inequalities in Europe. Mark, floor is yours.
So, good morning, ladies and gentlemen. First of all, I really don't know whether I have to say thank you to the organizer for giving me the opportunity to have this talk in this auditorium, because everyone who knows me well, they knows how I'm stressed when I have to speak English in public. So sorry for any kind of misunderstanding if I will try to explain something in my Czech English, because it's a really very, very important topic which I would like to introduce to you. It's some kind of overview about the policy advocacy and healthcare reform, and I will try to put together some roadmap. I didn't choose the sign yin yang by chance, because without incidents there is no mortality, and also the sign at the same time symbolize equity, and that's opposite on the inequality. So in 2022 there were about 2.78 million new cancer cases in the 27 EU member states plus Iceland and Norway. It means that 5 people were diagnosed every minute, maybe one cancer every 11 seconds. And it's estimated that by 2040, new cancer diagnoses will increase by around 18% in the EU. And even the mortality will decrease. The cancer-related deaths occurred in, and 1.7 million cancer-related deaths occurs in the EU in 2020, which was about 22.5% of all deaths. And even if the mortality decreased, it's much slower than on cardiovascular diseases. So by 2030 or 35, we think it will be, the cancer-related deaths will be the first reason of all deaths occurred in the EU. So the cancer care, it's some kind of whole continuum, and there are inequalities, and we have to beat them. So without decisive action, including beating inequalities, cancer will be the leading cause of death in the EU by 2035, and its burden will critically strain health and social systems. How we can identify the inequalities in the whole continuum of the cancer care? The first and the most important thing are national cancer registries. The national cancer registries are covering entire population, have been established in 24 out of 29 countries I mentioned, so not in 100%. And the scope of information, the timelines, quality and use of the data vary widely between the countries, and I marked with the green arrows some of the most comprehensive, and 5 of them, they also collect, for example, patient-reported outcomes or genetical information, which are also important for the future analysis. And expanding the scope gives the potential to yield stronger epidemiological insight and identify factors contributing to the inequalities. It's not only about the national cancer registries. Now we have another tool which we use for identifying inequalities, and it's a European Cancer Inequality Registry, which is a flagship initiative of the Europe's Beating Cancer Plan. And it provides reliable data on cancer prevention and care to identify trends, disparities, and inequalities between all these mentioned European countries and regions. And maybe you know, I'm sure you know, the most famous publications coming from this institute, country cancer profiles and cancer equalities fact sheets. This register is working with data coming from the Eurostat and those data coming from the National Official Statistics, OECD, IARC, and International Agency for Atomic Energy Agency, Joint Research Center, Cancer Mission, and the others. So we also believe that European health data space will establish standards for electronic medical record systems to enable greater interoperability and secondary use of the health data. What I would like to highlight, please, remember this paper, this publication that's about 250 pages, which came out in January 2024. And most of the things I'm now using in the presentation, you will find in this publication, which is free downloadable on the OECD iLibrary website, which is also mentioned on this slide. Well, inequalities, cancer burden. Cancer incidence and mortality rates vary across 29 European countries by 2 and 1.6-fold respectively, you can see on the map. And the burden of cancer also differs widely within countries and between regions. Cancer incidence vary by up to 100% and mortality up to 37%. You can see now the differences between regions with the highest and lowest cancer incident rates. For example, Bulgaria, Portugal, Latvia, Austria are at the end, which means they have the highest difference between the regions regarding the incidence rates. But it's not also about the incidence. Sometimes the data are not so correct, but the mortality, these data are usually much more accurate. And we can see also that there are big differences between the regions in the European countries. Some of them, for example, France, Romania, but also Portugal and other countries have big differences regarding the mortality within the regions. And maybe this reflects variations in the prevalence of risk factors, social and economic conditions, and access to the cancer screening programs, which is important to mention. So going to the second step, which is the cancer prevention. Worldwide, about 50% of cancer deaths among men and 1/3 of cancer deaths among women are attributed to modifiable risk factors. And around 50% of all cancer deaths are due to tobacco, alcohol, and metabolic cancer risk factors. So daily smoking rates vary almost threefold across the European countries and are about 50% higher among people with low levels of education or in the lowest income group. And you can again see on the map what are the biggest differences between the people regarding the education level. In the case of alcohol consumption, it varies about twofold between the highest and lowest consuming countries. And again, it depends also on not so much depend on the level of the education, but about the income, it's much more depending. And even if the consumption of the alcohol decreased, there are still countries which do about 11 liters of the absolute alcohol per year per inhabitant older than 15 years old, which is really enormous amount. Unfortunately, my country is one of the first on that chart with Latvia and Lithuania. More than half of adults are overweight or obese in 2019. And again, you can see how it correlates with the education and that example, which is for a woman age 15 plus. And 67% of people report less than 150 minutes of physical activities per week. And again, more than threefold differences regarding the European countries. Average outdoor air pollution varies almost fourfold across EU countries I mentioned. And except Finland, there is no other countries, all the other countries exceed the WHO limit threshold for the PM 2.5 particles. And prevalence of HPV infection varies greatly by country, and it's estimated about 14% for women in the EU countries, and it's sustainably higher in the Central and Eastern European member states, which is about 23%. And unfortunately, the proportion of vaccination is not so high in our countries, meaning the Central and Eastern European countries. So what are the policy actions to reduce the risk factors for cancer and target at-risk population? Of course, the most important now is the Europe's Beating Cancer Plan, which aims to create a tobacco-free generation by 2040, with the goal to reduce use of tobacco to less than 5% of the population. The most effective tobacco control policies, and that's very important that you can go through the document, you can find the best examples because it's summarized in the pages or on the end of all these chapters. The most effective tobacco control policies are tobacco, taxing tobacco, including the novel tobacco products, standardized packaging or large visual health warnings covering the whole package, to create a smoke-free environment, comprehensive bans on promotion, and of course to provide access to smoking cessation support. Regarding the alcohol, it's also, we have much broad spectrum of the policy actions which we can follow. There is an important WHO plan on global action for the prevention and control on non-communicable disease and the global strategy to reduce the harmful use of alcohol, which the plan is to reduce about 20% by 2030. Again, there are big differences regarding the EU countries, the lowest level of implementation: Austria, Belgium, Croatia, Cyprus, Denmark, Greece, Hungary. But also in our country, if you can look, not so many regulations were implemented, and that's maybe also the reason why we drink so much, but not the only one. So regarding the obesity and overweight, all 29 European countries except Greece have the adult obesity strategy, and child obesity strategy have most of them also. And there are also other policies to improve diets, increase physical activity, and address metabolic risk factors like health-related food taxes, regulation of advertising of unhealthy food and beverages, front-of-pack labeling. Many countries, they have a huge experience and good experience with that. Regulation of type of food and drink available in schools, physical activities and nutrition counseling. And what I was very surprised, about 10 European countries use the physical activity prescription in primary care, which is also very effective. Country and local policies promoting public transport, walking and cycling, and other important issues. And also, again, you can check the countries by the implementation of these regulation. HPV and hepatitis B and C, nearly all EU countries have a national policy of universal vaccination against HPV, and HPV vaccination is offered free of charge for both girls and boys in most of the EU countries. And again, strategy how to rise vaccination rates, extend the age category, and catch up vaccination for older. School-based vaccination programs. Nordic countries, they have a huge coverage of the vaccination, and they run these programs. Healthcare provider recommendations using the GP's advices, pharmacists, education and information campaign, one-dose regime, and also very important is the Jane Action Project Purge, which is now ongoing. Again, you can see the differences between our countries, how we implement and what are the strategies for the HPV vaccination. Cancer early detection. So screening and cancer early detection programs and policy actions. So we have a new EU Council recommendation on cancer screening, valid from the 2022, and it aims to ensure that 90% of the EU population who qualify for breast, cervical, and colorectal cancer screening are offered these by 2025. It's also one of the goals of the Europe Beating Cancer Plan. And there are furthermore other calls for extending the screening programs, like for lung cancer. 8 European countries now piloting this project. And there is also EU for Health Project Solaris, which is a trial in 10 European countries. Prostate cancer, 7 countries preparing the pilot projects. Czech Republic started in January this year, this project implement. And gastric cancer for those countries who have a high incidence of the gastric cancer and prevalence of the Helicobacter pylori infection. And also EU-funded projects which run these competencies among these European countries. Most EU countries have implemented population-based screening programs, but unfortunately, not all of them are on the national level, and there is also a huge variation in age ranges, screening intervals, methods, and wide variation in participation. In the case of breast cancer, not 100% countries have it, and you can see the variation in the age range for the inclusion of the citizen inhabitants to this program, and also the participation, which vary a lot of more than about half of the European, 11 out of the 29 EU countries, the participation in breast cancer screening is lower than 50% for women between the 50 and 69 age. Regarding cervical cancer, also not 100% of the EU countries with this screening program running, And you can see the participation in cervical screening in 9 of these countries is lower than 50%. And that's also something what is sad because it's completely preventable cancer. In the case of colorectal cancer, 22 out of 29 countries, and 9 only with the option of initial colonoscopy. And again, differences and the coverage. 2/3 of the EU countries have participation rates in colorectal cancer screening programs lower than 50%. So any other inequalities which we can address, and there are different programs which we can choose for beating with some kind of risk factors, and also one of the importance to increase the health literacy and to educate people, because most of these things are corresponding to the level of the education. So for the screening programs, the likelihood of having received the mammogram is about 10% higher among women with the higher education levels. I'm coming back to the previous slide. In the case of colon cancer, it's about 7%. And what we can use, what is the evidence, what is the practice of how we can improve the participation to the screening programs. For example, the intervention to improve the cancer awareness, like information campaign and specific initiatives to reach a vulnerable population. And those are adopted in many European countries. To involve primary health providers, to sending personal invitation letter accompanied by background materials for informed decision making, and to provide options to self-test at home. We have very nice experience regarding that with the HPV screening. We use a self-sampling test sent to women in deprived areas in the Czech Republic. Also, what is the evidence base for increase the effectiveness of the screening program is to use artificial intelligence for cancer screening. In Norway and Germany, there was already implemented policies on use of artificial intelligence application of the screening programs, especially for double reading supported by AI. And it's also supported by the European Cancer Imaging Initiative and the outcome project, and also the joint action ECAN. Fast-track pathways, which help to reduce the time between the cancer suspicion and cancer diagnosis and start of the initial treatment, which are running in Denmark, Ireland, Latvia, Lithuania, Poland, Slovenia, Spain, Sweden, and UK. And in Denmark, the fast-track pathway significantly improved relative survival rates for all cancer patients. 3-year survival rates increased from 45 to 54%. And there are also other activities to conduct research on the contribute to personalized risk-stratified screening. And there are a lot of international studies ongoing. I would mention MyPEPS, Perspective, and Joint Action Prevent and CD, using also the genetics and non-genetics factors to personalize screening. Regarding the cancer diagnosis and treatment, what are the inequalities what we have? In the precision medicine, the availability of precision medicine devices, sequencing technology, and their use in real practice is lower between the countries in the Central and Eastern Europe, comparing the Western and Northern Europe. The CT and MRI scanners, the availability of CT scanners, MRI scanners has increased almost in all of the countries. So there is maybe not so big problem in that. Mostly it's about the people who have to serve these systems. Robotic surgery, 21 of the 26 corresponding EU countries use robotic and robotic-assisted surgery, and the availability of robots has increased almost in all EU countries over the last 5 years. It's also very important because the robotic surgery help us to decrease the number of stay in the hospital and increase the quality of the life of the patients because they heal better. Regarding the cancer medicine, there is a threefold difference in public coverage of cancer medicines with the high clinical benefits across EU countries, and it doesn't mean that all eligible patients may have access in real clinical practice. You can again see that Central and Eastern Europe countries tend to have a lower use of novel cancer medicines as measured both cost and the volume. There are some exceptions. I'm very glad that also the Czech Republic is one of that. The coverage of the new drugs, new innovative drugs, it's really high from our health insurance, but it's only one case and we have to improve it. 1/3 of the EU countries use what is positive, use multidisciplinary teams and clinical guidelines for high standards of cancer care, but again, not 100%. And half of the EU countries have concentrated cancer care delivery, and over half of them have established cancer care networks to provide high-quality care, especially in the pediatric cancer. The centralization brought very positive results. In most of the EU countries, their cancer centers are involved in the European reference networks for international collaboration to care for the patient with rare cancer, e.g. Huracan, and few countries use mobile palliative care for patients at home. Another options how we can deal with the inequalities, and I was surprised how many provider accreditation certification are commonly used to ensure high quality cancer care in Europe. It's done in 16 out of the 29 countries, and over 65 cancer care centers in the EU countries are also accredited at the international level, and specifically in this document was mentioned the OECI accreditation and designation program. Also to reduce waiting times, which is very important, at least 1/3 of the EU countries have set targets, Denmark, Estonia, Finland, and the others. And over half of the countries monitor the quality of cancer care for continuous quality improvement. Sustainability of the cancer care delivery system. There has been a marked increase in the number of approved cancer medicine, as we said, an extension of indication in the past 2 decades. And global spending on oncology drugs is expected to grow by 14 to 17% per year. And providing access to these expensive new treatments is a challenge to even the wealthiest countries. So out of the 28 OECD countries, 23 indicate that budget impact is so increasingly influencing the coverage or reimbursement decisions of new cancer medicine, which is really very cautious. Another thing is a workforce shortage. Over 3/4 of the EU countries face workforce shortages in cancer care. Austria, Estonia, Latvia, Norway reported general shortages of nurses, which are resulting in negative impact on the delivery of cancer care. How to tackle workforce shortages? EU countries have increased training capacity, encourage staff substitutions among healthcare professionals, provide financial incentives, and recruited for again trained health professionals. You can see the different approaches have different policies what the different countries within the EU use to tackle this problem. Conclusion. From all these slides, Central and Eastern European countries dealing with a great number of inequalities in the provision of cancer care and prevention. I didn't speak, for example, also about the research agenda. Stronger action on prevention is urgently needed to attenuate the burden of the cancer on individuals, health expenditure, and also to society. And alongside national cancer control plans, the Europe's Beating Cancer Plan defines an overchanging strategic vision to help the EU tackle to cancer. And in order to make the data-driven decision to improve outcomes and close the gaps, countries need to link social economic data to high-quality cancer registries. And what is maybe the most important thing is building a strong community like we are, where experiences are effectively shared, is a proven way to overcome obstacles and address challenges. So thank you so much again, and I apologize for my terrible English.
Marek, thank you very much, and I'm pretty sure that we will have questions. Yes, please, Giovanni.
Giovanni Apollone. Professor Svoboda, thank you very much for a very, very good, excellent presentation, one of the best I have had the chance to see regarding the complex set of determinants of inequality, and also the presentation of the available tool, data, and so on, in order to be able to monitor the potential effect of given intervention at the national or the European level. So thank you again. I have just a request for you, because this presentation was very good, very clear, and I will ask whether it will be possible to have your slide available for the OECI community.
Yeah, thank you, Giovanni. I have to say that it was not my work. I just put all the things to the slides. It was taken from few resources. And one of the most important I really mentioned at the beginning, and please use it, it's free for download. And it's accompanied by detailed explanation of all this data. Of course, you can use it. Just let me, because I finished the presentation just a few minutes ago, let me check if all the slides are with the rightly written resources to do not make any problems for me and for anyone who will use it. So I will check the slides and then you can use it. Thank you so much.
Yes, please.
Yes. Hello, I'm Laura Pinavai and I work with the EONCOL project, and I'm a patient and I've done a lot of representing patients in patient organizations in Italy, and I've been to lots of conferences, and I just wanted to know what your opinion was on the role that patient organizations can have in this, because for example, in Italy, in Milan with Veronesi, Europa Donna, that was established, allowed us to have screening in Milan, and that moved around Italy. And so in Italy, we have a lot of breast cancer screening. And I know that where patient organizations are strong, there's been a lot of, awareness and healthcare improvement in cancer research and therapy. So I just wondered if you'd thought about that as well, how important what patient organizations can be in contributing and collaborating to maybe cancel out some of these inequalities.
Yeah, thank you for the question. You are completely right and you answered it. And it's coming also for our experience, because we have a very, very nice collaboration with patient organizations. Actually, we did with many of them, with some of them in Italy, from Italy, Hungary, Czech, Slovenia. We ran the project Intent together. And we also saw that if we engage the patient organization, the awareness is rising up. And in Czech Republic, we have more than 50 patient organizations. Of course, some of them are very active and they have a lot of members. And it's very easy to work with them. And there is also one umbrella organization which is helping us to share all the information and activity we need. And again, it's the best way how to effectively using the experience of others to increase the awareness. And that's also why one thing what we are trying to do in our institute. All the physicians and the nursing staff, we are ambassadors of the patient organizations, and we are giving some special booklet to the patients to read them and to be maybe a part of the patient organizations. It doesn't work like we would like to expect. There are about 5% of the patients are member of the patients organizations, but it doesn't matter the membership. If they are organizing some activities, sport activities, educational activities, I see full lecture halls, so they really work well, and they are very good partners in that very important task to increase the awareness of cancer.
Yes, Gennaro, please. Thank you. It's coming.
So the differences in the uptake in the screening programs is really impressive and dramatic. Does this correspond to a different level of investment in money spent by different states in screening programs?
Yeah, thanks for the question. Also in the paper is a chart which is showing the differences regarding the expenditure to the screening programs. Not only screening programs, sorry, it was about whole prevention. And even if those expenditure rise during the last 3 years, there are also money inside of this budget which were used for the COVID-19 prevention issues. So I think those coming for the screening programs are much more lower than what we saw in the chart in this paper. So yeah, there is a link between how many resources we have and what the number of the patients could be enrolled. This is one of the limits, but it's not only the one. Unfortunately, there are others, like also the trust of the patients and the relatives to those programs. And now we are dealing with many disinformations, and it's sometimes hard to explain the patients and the citizens and their relatives that, for example, HPV vaccination is safe and others. So it's not only one reason, but it's an important one. What was very nice to see, we went through because now there is a EU Resilience and Recovery Program, the national, which is on the national level called national, I will remember the right name. So the National Recovery and Resilience Funds, and many countries use the money from those funding to strengthen the cancer prevention and cancer care in their countries. For example, in our country, we are building a completely new cancer center in Prague, and building a new cancer prevention center in Brno, where I'm coming from, and sent about 3.5 million Czech crowns to other centers which do the cancer treatment and cancer prevention. And I saw many other countries who use these programs for strengthening cancer prevention and cancer care, so which is good.
So, please, Simon.
Sorry, I'm being awkward by being right at the back here. In terms of the EU and the influence of the EU on reducing cancer inequalities, obviously there are lots of actions ongoing at the moment, which will have hopefully an impact both on screening and treatment inequalities and outcomes. But are there any meta-studies that actually show the impact of basically what you presented, which is a set of inequalities league tables, you know, the worst versus the best. Are there any meta-studies to show that the mere revelation of those league tables actually has an influence on national policy making? That basically it's a kind of name and shame that Latvia or wherever looks at its things and says, my goodness, we've got to do something about this. We have to invest behind it. I mean, it's a great, because producing the league tables is absolutely, I mean, it's revelatory, isn't it? But how does that actually affect national investment and policy making?
Actually, don't know right now, but it's a good question because, you know, I think to start, the best idea was to start to produce these cancer country profiles. And it's very popular reading in our country, and we were trying to popularize it because also to show that the politicians how is the country profile regarding, for example, risk factors look like. And there is also the comparison with other European countries on those data sheets. So I think it would be nice to see if there will be some kind of changes in the policies on the national levels, but as I can remember the slides, for example, for the alcohol policy or the tobacco policy, I think nothing changed. And there are many best examples with the proved results regarding the decreasing the consumption of alcohol or tobacco in around the EU. So I don't know, maybe it could be better to simplify also these things to something like a traffic light for our politicians, see prevention and the policy for the prevention and all the countries with the traffic lights, and only maybe to have a sign of the red, orange or green, maybe the prime ministers or the ministries of health will just focus on that one point, oh, why we are red. Because sometimes to open the books and read in details, it's a problematic for them. Another thing is that not all the European countries, they have something what we can call, like for example in France, they have it, the National Cancer Institute, which is the institute which is analyzing the data, HT analysis, policy making and preparing documents for the policy makers. So it could be also the problem on some national levels that they don't have these resources to use and work with that. So don't know if there is some kind of paper looking on that issue. Maybe there is. Sorry for that. But it will be nice to check it. Thank you, Simon.
So the very last question for you is that do you see for OSCI a role in enhancing this investment on prevention and early diagnosis, that means screening, because it is a very important message?
Yeah. We saw it in our country, for example, for the breast cancer, cervical cancer. Now a little bit problem is that the colorectal cancer, but we are not on the end, we are in the middle regarding the coverage. Now we run, without the investment to that, we now have pilot programs for the prostate cancer from this year, for lung cancer from 2023. So without the investment to these programs, there will be no the success which we can see. But the problem is the primary prevention, because there is not so big investment on that. And they are proof that it works.
Okay, please.
Thank you again also for a very clear answer to the very complex questions. It's quite clear that there is a complex and interactive set of determinants of inequalities. And probably we can stratify them at a macro, meso, and individual level. And this is very important also because, as you had said in the first slides, the difference in inequality, this unacceptable variability in care and so on, and mostly in outcomes, are very relevant between countries, but also within countries. It means that some of these determinants are related to factors that can not very easy take into account with intervention at the European level that don't take care of some of these determinants within countries. Italy is a very good example, but also other countries have a very big difference in terms of healthcare organization, prevention, outcomes, and income and purchasing power and so on. Thank you.
Yeah, you're right. Also, we saw if you live in a rural area, it's always worse than in the urban area. Okay, maybe someone can give some questions on later. I'm really very nervous, but...
Okay, thank you once more for an excellent talk, and you can continue discussions on lunch.